are there attributes or benefits to virtual care that are actually not available in person?
Yeah, oh, for sure, without a doubt. I think a lot of them are practicality, so issues around not having to travel to the place where the therapist is, the costs of not having to travel, and, perhaps for certainly for remote people, the ability to get access to services that they might not be able to access otherwise. So again, this is not a new concept. It's been around in medicine for decades, and even within psychology or psychological services, it's been around now and researched for about, I would say, 20 years. So this is not that new. Some clients prefer not to come in for appointments, so they actually prefer not just the convenience, but also the privacy of potentially staying home. Sometimes it can actually feed into their the presenting problems. So for example, if it's a youth with social anxiety problems, sometimes they might prefer to stay home, and it might be actually easier for them to have that kind of an appointment than come and see somebody face to face. So again, there's some clinical reasons, but also convenience reasons.
Mhm. On the flip side, what about the what it's not able to provide?
Oh, well, again, there's many things, of course, and the nature of an interaction on a technological platform is different than an interpersonal platform. And from a clinician's perspective, again, we feel that there's many things that we don't get out of a distant relationship. So we can't see all of the body dynamics. We often see a lot when we meet a client, in the time just before or after the appointment formally begins, looking at how they approach the situation, the way they're dressed, the way they're taking care of themselves. So there's lots of nonverbal signs and signals that we look at as well that we really can't pick up that well in distance. So there's definitely some clinical issues like that. We also know that there are some people who have avoidance as part of their clinical presentation. So again, it could be social anxiety, it could be somebody with depression. And the fact of just having an appointment itself, having to come in and have a face-to-face contact with somebody else itself is therapeutic. So again, we don't want to feed into avoidance if that's part of the clinical problem.
Hmm.
Yeah.
Uh, how do you get around? I mean, some of those things won't be solvable, but are there ways to improve it? Perhaps that you're learning on the fly as this develops.
I think we're learning how to do sort of second best. So, for example, in the context of cognitive behavior therapy, we often have assignments, like I said, and oftentimes we get the client to either bring us things that they've worked on. So it could be homework sheets, for example, or it could be records of things that they've done, or even sometimes pictures of places they've gone, if that's the work. And so a lot of that can still be done through distance, so we can still see, an image of a sheet, for example, or you can even share a screen sometimes. And so a lot of the work can be overcome, or a lot of the obstacles can be overcome. It's really more the interpersonal dynamic and the relationship and the ability to read the person fully. It really becomes more of the challenge, I think.
Mhm. Um, are there particular challenges when you're moving over a younger person from in-person care to virtual?
Yeah, so some of the issues, of course, with youth are things like informed consent. So legally in Canada, until you reach the age of majority, unless you're a mature minor, you should have a parental or guardian consent for care. And so one of the things you need to do is respect privacy of the client, the youth, but also, of course, the legal rights of the parents. And again, when people are living in tight quarters, it's sometimes difficult to maintain the respect for autonomy, that the youth might want and need in order to do therapy, especially if people are having their computer in an open area where others might be able to listen in. This can be a real problem or impediment to providing services. For youth that are maybe on the borderline of being able to be what we would call a mature minor, so somebody who's in the roughly 14 to 18-year range but understands what they're doing, legally they can give informed consent. But again, if the parent is in the background, literally in this case, then that can be much more difficult for the clinician. And also, again, the ability to really understand if the client understands what they're consenting is more difficult through a distant platform than seeing it face to face. So there are some issues like that. From a liability perspective, also for clinicians, if they want to give mature minor status, for example, what you should be doing is ideally seeing the person face to face and having them sign an informed consent. And of course, we can't do that distance. So there are some technical issues that also become more problematic for sure.
In terms of how needs are evolving, are people coming to clinicians with different needs in the COVID era?
Well, without a doubt, I think the general nature of the concerns are similar. But I think the form that they're taking are shaping up a little bit differently. So for example, in COVID-19, we know there's been a lot of anxiety about social contact and about, for example, leaving the home and interacting with other people at the grocery store, places like that. Youth don't have to deal with those issues quite so much, but young adults certainly do, if they're out shopping and having to interact with the world. So lots of concerns about safety, lots of like personal safety, physical safety, sanitation, again, lots of those kinds of issues. With adults more, and again, some of the young adults are seeing this as well, you find issues around employment or precarious employment or potentially even unemployment, people losing their positions as places shut down. So a lot of financial insecurity, a lot of worries in that direction. We've certainly heard reports of increased domestic issues, so children being subjected to violence at home or witnessing violence at home. So there are those kinds of issues that are certainly increasing as well.
As restrictions loosen over time, what do you think will happen to the provision of virtual care?
Yeah, that's an excellent question, and I think we're all fascinated to see what the solution will be, the longer term kind of response. My prediction, and again, it's just that, is that we're going to see something of a movement back towards face-to-face therapies. My suspicion is that most clinicians prefer to see their client face-to-face at least once, perhaps during the informed consent process and during the assessment to really get a good sense of the individual and what services they might need. But that as the care moves along, it might be quite possible to move towards more distant therapy or either phone or video kinds of connections. So my suspicion is that over the longer term, we're going to see a much more use of distance technology in the provision of psychological services.
Mm-hmm.
How much we'll do that and for how long, I don't know, but I'm guessing this is a permanent shift. The data suggests that these services can be effective and almost as much, like I say, as live services. And we've known that for a while. In fact, that literature is quite well developed now from a research perspective. And so the question has always been, how are we going to implement it and who's going to fund it? And now that there's a funding mechanism and there's the real need to develop these services, like you say, my guess is we're going to be doing that development work, to see how the services can actually be delivered on a large scale. And my prediction again is that once we don't have to do it this way, we'll continue anyway, because we'll find that in fact it is effective for many people. With some of the technologies you can record. And so, if you record, you could potentially play back the recording to somebody else who wasn't there. And again, it raises other kinds of concerns or questions about privacy. So again, I think it just has to be done with informed consent and, the clientele has to feel comfortable. The reality is that some people might not. And so some people might decline to receive services as a consequence. I was supervising some people providing services through the University of Calgary clinic. We have a psychology clinic. And when the COVID-19 crisis happened, we had to transfer from live to distant therapy. And we did lose some clients. Some just said they weren't comfortable going online and doing it technologically. So
Mm-hmm.
that will happen. Some people will definitely not get services.
Right. Sorry, was that a group therapy, or could you tell me a
No,
little bit more
those
about?
are individual. Those are individual clients.
Okay.
And the interesting thing, I guess, one of them in particular who immediately said they weren't interested was a younger man. He was in his early 20s, very technologically skilled, actually worked in IT, and said he just wasn't willing to make the shift.
There's a lot of talk about how society in general can reshift and
Mhm.
be better for the experience.
Yes.
For the provision of mental health, what would you like to see
The Canadian Psychological Association has for a number of years now advocated the need for increased access to mental health services. And the Canadian Mental Health Association, no, sorry, not the Canadian Mental Health Association, the Mental Health Commission of Canada, which has also studied this issue, has also taken a similar position that access to psychological services is not what it should be in Canada. And in mental health services in general. We know that the percentage of psychiatrists, for example, in the country will never be sufficient to meet the mental health needs. So we need to have other people doing mental health services. So social workers, nurses, psychologists certainly have a role to fill. My hope coming out of this is that access to psychological services and psychotherapies, broadly speaking, or psychosocial interventions will be enhanced. Whether it gets enhanced through increased access to personal therapists live or whether it's done through telepsychological methods, I don't think it matters. But increased access to services, I think, is the key thing. The other part about services, of course, is that we know a lot now about which kinds of psychotherapies work in general, for specific clinical problems and which ones maybe don't have as much evidence. And one of my personal hopes is that it won't just be general access to providers, but especially access to evidence-based therapies. So those that we know tend to work for different clinical problems.